Let's lastly just look at a few pitfalls and some areas where you may make mistakes. And hopefully you can avoid these mistakes by recognizing them and what they look like. The first one, we alluded to this earlier. We talked about what lung point looks like and what lung point means. So here we see no sliding here, and then we see some sliding kind of moving up and down here where this patient has an pneumothorax. And this is the interface where lung is up versus where lung is down. This is lung point. Lung point is almost 100% specific for pneumothorax. So if you see this, the patient has a pneumothorax. What you do about that depends on the entire clinical scenario. So again, lung point, 100% specific for pneumothorax. Again, how you manage it, clinical scenario. Important to recognize things that may mimic lung point. So anything that's up around the chest wall close to the lung may mimic a lung point. So here, kind of see the pleural line, we see it sliding, we see it moving, and we see a change here. Now, why we see that change is because we're right next to the heart. And so as we move, the patient breathes, the heart beats, we see a false lung point. So don't mistake that for a true lung point. Don't diagnose this as a pneumothorax. Similar thing here, we're just kind of getting close to the abdomen. So I believe we're catching, I don't know if it's liver or spleen, but we're catching another solid organ. So recognize where you are on the body. And because we see sliding here, it doesn't look the same over here, it looks different. But this is where we're just kind of at the interface of abdominal organ and lung. So this may also mimic the appearance of a lung point. Don't let that fool you. Don't diagnose this as pneumothorax. Just recognize what a true lung point looks like and differentiate that from some of these things that may cause a false lung point. There may be fluid in the chest, could do a similar thing. There could be other chest lesions like an infiltrate or something like that. If you're not sure, move the probe to a different area and look and see if the lung point persists, or if you pick up something that looks like fluid or a solid organ or the heart or something else. False lung point, don't let it fool you. Just some other things, and we talked about this a little bit, things that may inhibit pleural sliding. Most of the time, pleural sliding, you can see it just passively. You don't even have to have the patient breathe. But if you're not sure, try to ask for a deep breath, or if they're on the ventilator, ask someone to give them a big bag to see if you see sliding or not. If they are splinting, so they have chest wall pain because they broke a rib or something, they may not be moving air very much, and so you may not see sliding. So if you're not sure, ask for a big breath or give them a breath with the bag. If you've intubated them and you've done a right main stem, you may look on the left and you don't see sliding. And that may just be because you're not ventilating that side and there's no lung sliding. So consider that before you place a chest tube. If they've had surgery in the past and they've got some kind of pleural scarring, or they've had other procedures, then they may have some scarring at that pleural line that may inhibit the pleural sliding as well. So just keep that in mind. That doesn't happen that often, but there are some things that may cause a loss of pleural sliding and can give you a false positive for pneumothorax. So keep those in mind and use some techniques to avoid those pitfalls. So we looked at this before. This is what kind of normal sliding looks like. You don't even need breaths to see this most of the time. It's just passive. If you see little comet tails, those little tiny artifacts we talked about, they have different names. But if you see those little things jutting down from the pleural line, then that is a good indication that the lung is up. Comet tails equal lung up, not a pneumothorax. Sometimes we might just see the chest wall or the pleural line move with cardiac motion. So this is a lung pulse. If you see lung pulse, it doesn't quite look the same as sliding. It's a slightly different movement, but we still see pleural line moving. So lung pulse equals lung up. This is not a pneumothorax. So other things, if sliding doesn't look quite the way you expected it, other things to tell you that the lung is up. So this is lung pulse. You may see this even if there's no ventilation happening at all, especially on the left side. If you see B-lines, so you see the pleural line, and there's not a lot of movement here. There's not a lot of sliding going on. But if we see little B-lines coming down from the pleural line, well, you can only get B-lines if you're seeing the lung with interstitial fluid. So if you see B-lines coming down from the pleural line, then the lung is up. There's not a pneumothorax, just other clues. So comet tails mean lung is up, B-lines mean lung is up, lung pulse means lung is up. Those are the kind of pitfalls in the chest. Let's talk about this patient here. It's got a motor vehicle crash, they've got normal vitals, but they've got abdominal pain. When we look at this image here, pretty negative, right? They might have a little hydronephrosis, that's an incidental thing, but looks negative. I borrowed this from my buddies over at Core Ultrasound. Check out their webpage and their Twitter handles if you're interested. But if this case demonstrates, this is why we talk about getting down inferior to the liver tip into the paracolic gutter. Fluid accumulated here at the tip of the liver, in the pericardial gutter. This is why your exam is not complete until you've seen above the diaphragm, below the diaphragm, and down below the organs, down towards the feet in the pericardial gutter. If you don't look here, you're going to miss this sign of bleeding in the abdomen. So that's one of the other pitfalls, not doing a complete exam. So this is just another example. This right side looks pretty good, nothing in Morrison's pouch, but as we slide below the kidney towards the feet, here's the lower tip of the kidney, we see the outline of the bowel, fluid in the pericardial gutter. If you don't include this in your exam, you're going to miss blood in the abdomen. Here's another pitfall, and this happens a lot, especially in the parasternal long axis view, if you have to get that one. Fat pads can mimic pericardial effusion. We have to recognize them and differentiate them. So here we see the heart, here we see the fat pad, and this can be hard to differentiate from pericardial fluid or blood, especially because we talked about blood can be gray when it starts to clot. Your clues here: it's all anterior, it doesn't wrap all the way around, it mostly keeps its shape throughout the cardiac cycle, it doesn't change shape very much, and it's got little gray, pretty regular distribution of gray flecks and things within it. So those are clues that this is just a fat pad and not pericardial fluid. That's always the question: hemopericardium or fat pad. Differentiating these can be difficult. It's probably one of the most common curbside consults I get. Is this a fat pad or pericardial fluid? In this case, we kind of talked about already, this is a fat pad. So here's another example. What's this one? It says hemopericardium or fat pad. This is a tough one, but I'm going to give you some things to look for. One, we see a little bit of fluid wrapping all the way around back here. See, there's a little bit of fluid, so it's circumferential. Now, this doesn't change shape very much, but some of it's black. The fat pad had that regularly distributed gray. This does not. We can even see some of this is fluid density. It's a little subtle, but there's a little bit of fluid density here. This is gray hemopericardium. This is a tough one, and if you're not sure, you get some different views, change your depth, change your angles. You may need additional views, but you definitely want to recognize this, right? This is fluid around the heart. It's circumferential. There's different shades of fresh blood and clotted blood. It doesn't change shape that much because it's starting to clot, but this is subtle hemopericardium. One of the toughest cases I've seen. Keep that in mind, but critical to get right. This is hemopericardium. A few more examples. These can be tough. These are examples of how fat pads can be big. This is all fat pad wrapping around, but it's not circumferential, and it's pretty much all the same shade. Keeps pretty much, it gets thicker and thinner a little bit, but it doesn't really, there's no waving. It keeps mostly the same shape. This is a fat pad. Again, we don't really see much around the back. There's not much in the dependent areas. It has these flecks of gray. It keeps mostly the same shape. And if you're not sure, again, get some different views, different angles to help you decide. These are both fat pads. These are effusions. Here we see blood. It's pretty black here. There's a lot of shape change throughout the cardiac cycle. There's a little bit of it posteriorly, so it's circumferential. That's always a big clue. And same here, we see fluid in different parts of it. We see some of the fluid wrap around the back. Posteriorly here, we see a little bit. We see the shape of it changing significantly. And we can even see here, it's compressing the left ventricle. So that's another clue. If you're not sure, get some more views, get some different angles, but be wary of pericardial fluid in trauma. Some subxiphoid examples. Here we see some of the blood is starting to clot. See, it's kind of gray, but there's fluid circumferential to the heart. Some of it's gray, some of it's black. We've got different shades. Same here, it's circumferential. There's different shades of black and gray, lots of shape change throughout the cardiac cycle. These can be difficult, and especially difficult because it's not, depending on your work setting or your clinical environment, trauma to the heart may not be that common, so you may not see it a lot to recognize the differences in these subtle cases, but critically important in some of these patients. Oh, I think we were beating this to death, but here, this is an example of a fat pad. This one doesn't wrap all the way around, keeps mostly the same shape. You don't get a sense of the heart floating in a bag of fluid. This is another fat pad. This is one where it's kind of loculated, so we see a large area of compression. This is a little bit of a difficult one, but this is a loculated pericardial fluid collection. We see some of it circumferential, so that's a big clue. And we see compression on the right ventricle. That's another clue. So this is pericardial fluid or blood in the pericardium. And the last one, again, beating it to death. This one keeps mostly the same shape, a little differentiation, but it does not wrap circumferentially. It's mostly a homogeneous, kind of regular flecks of gray. This is another fat pad. In this example, we see fluid circumferential to the heart, a little bit of it anteriorly, a lot of it posteriorly. It tracks. We didn't talk about this much before, but if you find the descending thoracic aorta, which is here, this fluid that tracks between the heart and the descending thoracic aorta, that is pericardial every time. So this is a pericardial effusion in the peristernal long axis view. Recognize that. This is a difficult one. This is another localized, loculated pericardial fluid collection. You can see it compressing the right ventricle here. Right there it is. Now this is not even going to be visible in every other view, but this definitely needs addressed some way. Here are a few others. Here it's mostly posterior, but it's dependent, and it separates the heart from the descending thoracic aorta. You see that there? So this is pericardial fluid, and we can see how the pressure changes are affecting the ability of the left ventricle to fill. And in this example here, again, large pericardial effusion, circumferential to the heart, compressing the entire heart. That's another example of pericardial fluid collection. If you see this in trauma, then you've got to treat this. How you're going to treat it depends on your setting and your resources you have available to you. So enough with the heart. Let's look at a few other kind of pitfalls of things we might see. This is a view from the right side. The question is this a positive or negative FAST exam? Take a look, think about it, come up with your answer. And the answer is it's negative. Anything that has fluid in it can kind of mimic peritoneal fluid. So in this case, we're actually catching the inferior vena cava back here. We can even see the abdominal aorta through the way we're slicing this. We just need to kind of, again, this is why we examine completely, continue to fan ceiling to floor to see the relationship of the kidney and the liver and these other organs. Any fluid-filled structure, see how it's nice and linear? That's a clue that this is a normal structure. We see some other fluid-filled structures like the portal vein and hepatic veins, aorta back here. So don't let these other fluid-filled structures fool you. And one of the most common ones on the right side is going to be the inferior vena cava, but also portal vein, gallbladder. You can have cysts anywhere, cysts in the kidneys, cysts in the liver. Sometimes bowel loops that have fluid in them can also mimic peritoneal fluid. Take a look at all those things, compare the shapes. So here's another example. Again, here we see the diaphragm and we see this kind of linear looking, let me pause that a second, linear looking structure that may look like free fluid in the abdomen. But see how it's linear, kind of takes a shape. It's not in the diaphragmatic space. It's not in Morrison's pouch, it's not in pericolic gutter, and it's linear. This is the inferior vena cava. This can be one of the sources of a false positive FAST exam if you're not used to recognizing this and seeing how it looks. And as you fan through, you can see its relationship to the kidney and how you're even seeing the abdominal aorta back here. And that may be a clue that this is not free fluid. So one of the caveats. Here's ones that come up a lot, and these can sometimes look like it's right in Morrison's pouch. But if you follow it and fan through, you see how it takes a shape, even has a wall. This is the gallbladder. This one could look very convincing if you're not careful and if you're not attuned to your normal anatomy. So the gallbladder, another fluid-filled structure, can mimic free abdominal fluid. Don't let this one fool you. A few other things, you may see hydronephrosis. Now, if you see hydronephrosis, you may have to ask yourself, why does this patient have hydronephrosis? It's beyond our talk today, but this could mimic free peritoneal fluid. Just recognize how this fluid is contained. It takes on a shape and it's within the kidney itself. Hydronephrosis, you may see renal cysts, but again, they take on a shape. It's got this nice rounded shape to it. It's not just filling potential spaces in the abdomen with the little pointy ends down at the bottom. It's got a shape. It's within the kidney parenchyma. You fan through it, and hopefully you recognize this is a renal cyst, not free peritoneal fluid. So here are some examples of true peritoneal fluid. What you want to recognize, one, it's in the defined areas we talked about, those potential spaces. So here, subdiaphragmatic, Morrison's pouch, and it just fills whatever available space you have, and it takes on little points as it just goes down and fills up whatever's there. Same thing here. We see it compressing the colon and just filling the available space, and you can kind of see these dependent little points, pointy structures at the bottom, let you know that this is probably free peritoneal fluid. It's not contained within any other structure. It really doesn't take on any nice, well-defined shape. And then we kind of talked about this caveat already, so I won't beat it to death, but just recognize this gray stuff is blood. Blood can clot, it can look gray. Make sure you recognize it. So that's a positive fast exam. Just a few other examples of that. So here we see kind of mixed liquid and gray, but this is blood contained within the abdomen, somewhere in the paracolic gutter. So we see gray, clotted blood, some liquid blood all around it. Here's one Dr. Robert Jones sent out on Twitter, where you see blood in Morrison's pouch. You see a little bit of the liquid, but this can be very difficult to recognize if you didn't recognize clotting gray blood in the wrong place. The little bit of black around it's a clue. Hope maybe you get some other images to help you recognize this, but clotting blood can look gray. A further example where we see here a little bit of blood in Morrison's pouch. There's probably a liver injury here, and we see lots more blood down at the lower portion, the inferior portion of the liver and the paracolic gutter. So just be complete, good fanning movements as you examine the abdomen to find these areas of bleeding in the abdomen. Here's another case that's a little bit subtle. We're on the left side here, and we see that the spleen does not take on its normal contour. It should be kind of this nice pointy crescent moon, but it takes on this bulbous appearance here. As we look closer, it's a little bit heterogeneous. Here we see the borders are interrupted just a little bit. There's probably some subtle fluid here. And we see some heterogeneity here at the spleen tip, and it's bigger than it should be. Should be a nice, pointy little crescent moon, and we don't see that here. This is a spleen injury. And then lastly, we've looked at examples of this already. Blood can be gray in the pericardium. Look for these examples. I think we beat the heart to death, so I won't beat it to death any further. Some of the things in the lungs and pitfalls and little pearls to recognize. A lung point is 100% or approaches 100% specificity for pneumothorax. Just beware of the false lung point, other things that can mimic this, like fluid, solid organs, the heart, things like that. And also recognize if you see the lung pulse, if you see small comet tails or B lines coming down from the pleural line, that means the lung is up and there's not pneumothorax, at least in that area. So those things mean lung is up. Hemopericardium, look for fluid to be circumferential to the heart. Does it change shape significantly throughout the cardiac cycle? Does it move a lot? And what is the distribution of the gray in that fluid? And then there's lots of things that cause a false positive fast in the abdomen, fluid-filled things like the inferior vena cava, gallbladder, cysts, portal veins. And then you get physiologic fluid, especially in women of childbearing age. But sometimes even children, you can see physiologic fluid in the abdomen. That can get a little more difficult. Didn't really show examples of that, but just remember, females of childbearing age may have physiologic free fluid in the pelvis. In some scenarios, children and even young adults will see small amounts of physiologic free fluid. So if you see that, you're going to have to incorporate that with the entire clinical scenario and decide how to deal with those findings. Kind of lastly, blood can clot quickly and it can look gray. You can also recognize irregularities of solid organs. So step one is recognizing what normal solid organs look like, and then irregularities in those solid organs will stand out and you can identify those early. Again, you can't exclude injuries to those organs, but if you find them early, that may help your management. So we talked about a lot of things. We talked about when to do the fast, how to do the fast, what things look like, what some of the abnormalities look like, how this can influence our decision making. And then lastly, we went into some of the less common but subtle findings you may see, and then some of the pitfalls and some of the things that might cause false positives. So just to summarize and sum up kind of everything we've talked about and kind of keep some of those key points in our memory, let's go through a little summary. Now, first I'm going to say things we didn't talk about, and this may not be relevant in your setting, depends on where you're working. If you're doing international medicine or global health, some of these things may be relevant to you, but we didn't talk about how we can use ultrasound to identify fractures. We can identify widening of the pubic symphysis if we can't get x-rays quickly for some reason, and recognize unstable pelvis fractures, the optic nerve sheath, and head trauma to help us differentiate maybe intoxication versus brain injury. And then all the procedures that we may need to do in trauma patients, like vascular access, or if we're doing a temporizing pericardiocentesis, or if we even need to do paracentesis because we're not sure if this is chronic ascites versus blood in their abdomen. All those things that we can do with ultrasound to help us manage the trauma patient, art lines, those things. So we skipped all of that, but those are kind of emerging areas or areas to look at. And depending on what your clinical setting is, if you're doing kind of remote EMS or global health, some of these things may be more relevant. And I always like to talk about, we think of the FAST exam as one of the most basic things we do with ultrasound and one of the more basic things we do with trauma. But the more basic it is, the more mastery is required to do it well. and to not make mistakes. Just reminders about the image acquisition. We'll start in the chest, unless you have a different order you like to go in, but look for pneumothorax, then look at the heart. Examine the right and left side from above the diaphragm to the pericardic gutters, and then look in the pelvis right above the pubic symphysis. Remember how those angles want to be. Remember our rough decision making. If we have a positive FAST and the patient's unstable, then there's probably an intervention they need. Chest tube, thoracotomy, laparotomy, maybe a temporizing pericardiocentesis. But if they have a positive FAST and they're stable, then they can go on to further workup and imaging, but they're going to move up the list. You're going to direct more resources in their direction. If the FAST exam is negative and they're unstable, then probably what you're going to do is resuscitate and repeat the FAST in 10 or 15 minutes. Not that likely you're going to do a DPL. That is a consideration versus an accompanied CT with appropriate resuscitation measures on the ready. And then more importantly is if stable with a negative FAST exam, those are patients where you can use a little bit more critical thinking and decide, are they high risk? Do they need a CT scan right away? Or is this someone who can forego immediate CT and we can follow clinically and hopefully decrease some of that overexposure to ionizing radiation and cost and contrast that we tend to do a little too much of in trauma patients. Didn't talk about this too much. We talked a little bit about penetrating trauma, but penetrating trauma, the heart is going to be one of the most important things to look at. So if they have penetrating trauma, you want to see if they have tamponade that you can quickly address, and that may affect, if you're working with your surgeons, how their surgical approach is going to go, if the patient can go to the operating room, or if you need to do a bedside thoracotomy. And then we didn't talk too much about this, but in patients with penetrating abdominal trauma, free fluid indicates likely intestinal or other injury that likely is going to warrant exploratory laparotomy. That may help some of that decision making, whereas in the patient with penetrating abdominal trauma and no intra-abdominal fluid, then you may go down the pathway of further imaging and clinical observation in some settings. Obviously, that's going to depend a little bit on your clinical scenario. You're going to be discussing that patient with surgical consultants, so I don't want to make any definitive statements or prescribe any specific clinical care, but there are some settings where penetrating abdominal trauma does not always require immediate laparotomy, and the FAST exam can help a little bit with some of that decision making. A little bit beyond our scope, but something to think about. And I think it's important just to reemphasize kind of the thinking around pneumothorax. The biggest thing is if you see the pneumothorax, then you incorporate the rest of the clinical picture to help you decide, does it need immediate intervention or not? If they're pretty okay and pretty stable, then it probably doesn't need immediate intervention. You have that information, you know about it, and if the patient decompensates, you can act on it. However, if you see pneumothorax and the patient's sick, either from a respiratory standpoint or in shock, then you should probably go ahead and act on that finding. And then just to hit those last key points one more time, remember we can only make 4 diagnoses with confidence with ultrasound and trauma, and those are hemopericardium, pneumothorax, hemothorax, and hemoperitoneum. This can affect our decision making if they're unstable. Immediate intervention is necessary and we start acting on that. But even if they're stable, we get added information that helps us allocate our resources and decide how to manage that patient in the context of a department full of sick patients. That's everything I have for you on ultrasound and trauma and the FAST exam. I hope you found it helpful, and I hope you'll tune in for our next point of care ultrasound web course, and I hope to see you in some live scanning sessions soon.